Delighted to introduce our next speakers. So we have Rue Abaratne and George MacDonald, who are both from the University Hospitals Leicester NHS Trust, who are going to be talking about emergency department attendances, intersectionality, demography and patient complexity. Rue, I can see you on screen. Welcome. I shall hand over to you, and apologies, I hope I pronounced your name correctly. You're on mute.
You can hear me now, can't you?
Yes, we can.
Morning, everybody. Yeah. I'm not going to lie, George and I had a bit of a nightmare getting in, so he's on his way, will join us, but I will start by sharing my screen. Now, can you see what I'm sharing? I can't tell if you can see. Aha, perfect. So my name's Rue. I am consultant geriatrician by background, and I am also director of health equality inclusion at University Hospitals of Leicester. George, who I'm hoping will be joining us shortly, is a data engineer and scientist who I've been working with for a few months now. And George and I have been trying to do some work around the intersectionality of our patients, thinking about health inequalities, emergency care demand, and flow through our emergency department. So I will take you through some of the analysis that we have been doing. When I first started this work around health inequalities, we were conditioned to talk about patients in terms of their demographic groups by protected characteristics. So there are 9 protected characteristics, but we largely focused on ethnicity, deprivation, and age, occasionally gender. But we know in practice that actually emergency departments and the hospital often focuses on flow and pathways that patients are in. And so how a patient as an individual and their characteristics fits into a flow pathway and how those characteristics might impact a pathway are integrated and intrinsically linked. One of those things is really fixed. So, for example, the protected characteristics, and the other thing, that is the flow and the demand into our system, is much more dynamic in a more dynamic state. But what we're trying to do here is work together to understand how protected characteristics, patient demographics impact our patient flows and our operational resilience. So it doesn't surprise you, I hope, to realise that the demand in our system is impacted by inequalities. And in Leicester, we've described that as largely our more deprived populations present into our UEC pathways with more frequency and less acuity. But actually what we've started to describe is a much less obvious pattern, which feeds then into how we plan our services and develop our services. So what we need to be able to do is to determine upstream of a presentation what it is that's going to drive health-seeking behaviour and when the need might arise, and how then our ED can respond in a dynamic way to changes in flow. Just to give you some kind of context around our population, Leicester City has a lower than average healthy life expectancy. And when I'm asked to describe the problem we're trying to solve around health inequalities, it is that we need to improve healthy life expectancy, particularly for our most disadvantaged colleagues and for, communities. Interestingly, though, the only demographic in Leicester, and Rutland, so within our integrated care system, that doesn't have a below average healthy life expectancy are white males who live in the county, so that is Leicestershire. So we've got a real focus of below average healthy life expectancy. Leicester City is one of the most deprived local authorities, and I think that's a common statement for lots of systems that I talk to, but it is in stark contrast to some of our other local authorities that we serve, where in the most recent publications they were the highest level of, or the lowest deprivation, highest level of affluence. We have a plural city, so there is no ethnic majority in Leicester, and the population really shapeshifts because we are a university city. So the city is increasingly youthful, the city is increasingly ethnically diverse, and the county is starting to see impacts of that too. Health literacy is a real problem for us, and digital exclusion is really variable. So whilst deprivation is a challenge for us in the city, we know that digital inclusion is a challenge because of literacy rather than tech and access to tech. And then if we think about our hospital and the service that we offer, University Hospitals of Leicester has one single site emergency department for a population of over 1 million people, well over 1 million people. It's the biggest single site emergency department in Europe. Attendances have grown year on year, and to the point now where exceeding 1,000 attendances a day is a regular occurrence. We're no longer shocked by that here in Leicestershire and Rutland. So something needs to be done in terms of linking our population, the dynamics of our population, and the behaviours and trends and demand that we are seeing in ED. So I'm going to hand over to George, who has appeared. Hopefully George's tech is working now, but if not, I'll take over. George, just tell me when you want me to move the screen on. I'm hoping George is going to appear. Okay, I'm going to carry on talking, and if George comes back to us, then I will hand back over. So we've taken a look at over a year's worth of UEC data to try and look at waiting time variation.
I think George, sorry,
It's okay.
George, I think you are on. Can George, you're on stage, are you not, George? Can you talk? Can we hear you? Oh, maybe he can't hear us. Can you not hear us, George?
You can, sorry, my name is.
Okay, no, I'm sorry. I think we've got some tech issues. Sorry, I thought that was going to work, and it hasn't. So we'll move straight. We'll move straight.
What's going on, to be honest.
I can hear George. George, I'll carry on, and if George can chip in, then do so. So hopefully you've had time to have a look at the slides. So these are the demographics that we looked at, ethnicity, deprivation, age, and we were really keen to pick out acuity and frailty and how that's impacting demand. And we've looked at both our admitted and our non-admitted pathways. So I will take you through some of the results. So if we talk about adult attendances first, so what we can see here is that by ethnicity and within the age category 50 to 69, you can see a clear hotspot of focus of activity. But when we take a look at the same age brackets by ethnicity, it's really interesting to see that the hotspot of activity persists for the age bracket. But when you start to look at deprivation, you can see that younger patients start to pitch up more to our ED from more deprived communities than from less deprived communities. When we look at paediatric attendances, we have a similar kind of pattern, but in a younger group of patients. So the demand is greater for our younger groups of patients compared to our older groups of paediatric patients. But actually, as you start to look at deprivation, it's age that's driving it rather than deprivation being the factor as compared to the adult attendances. I am cantering through these because I'm aware of the tech issues having slowed us down a little bit. So hopefully what this slide can summarise for you is what you've seen in those two heat maps. So attendances are concentrated in age ethnicity brackets rather than age deprivation brackets. And what we've found is that most of our demand in adults comes from white 50 to 69 year olds. And actually, if we disaggregate that further, it's much more skewed towards older patients. And in paediatrics, white ethnicity patients are dominant, but in a younger cohort rather than by deprivation. What I really must caveat this with is that whilst Leicester City is a plural city with no ethnic majority, the county has a white majority population. I think that's really important for us to remember and understand data. So this is just a reference to the fact that what we're seeing in our results isn't necessarily representative in the city of our population data. So that reference to a plural city and high levels of deprivation. When we've taken a look and tried to overlay clinical information into this data analysis, what we've seen is that white populations generally are presenting to us with a higher acuity. And the way we've looked at acuity is through early warning scores, but also DPS scores, so dynamic priority scores. George, feel free to come off microphone if you can hear me and try and chip in, because if I can hear you talking, I'll hand over to you.
Yeah, I think, is everything working now?
Perfect.
So sorry, everybody, if anyone's watching this. Okay, so So do you want me to carry on, Ru? Or
Yes, please.
Cool. So the key takeaways from sort of the heat maps that have just been shown is that we've got deep demographic intersectionality. So white patients are also older. I'm saying is that so these ethnicity effects in other patient outcomes that we look at might actually just be age effects. And then with it among pediatrics, we're seeing the majority of focused on the very young, with a more even spread across levels of deprivation. And then I think finally it's really key to highlight that point that Ruth's been talking about. We often assume that high attendance in a group reflects overuse. Actually, we're kind of seeing the opposite here. Population and presentation acuity data suggests this isn't the case. Sorry, next slide. Next one, sorry. So now I'm going to turn and look at wait times. These are simple pooled OLS regressions. So we're checking all data in from those 22 months, and we're looking at the differences in wait times between the different ethnic groups. These are, as I said, these are ONS groupings. What we're seeing, somewhat surprisingly, whether we look at binary or continuous outcomes, is that white patients are waiting longer, and that those relationships are statistically significant. And also, I think the other thing to highlight here is that the raw result, or the unadjusted result, is really quite large. When we add in a control for age, we're seeing that coefficient to decrease, but not to the point of statistical insignificance. So we've got big difference between Asian and white populations and Black British and white populations, just to highlight that. Okay, next slide, please. Thanks. So what we're going to do now is we're going to try and decompose that ethnicity gap that we've just seen and look particularly at the white and the Asian groups. And what we're seeing is and we're going to standardize the waiting time gap, just because of the fact that admitted patients generally wait longer than non-admitted. What we're seeing is that the gap in the admitted population is much larger than in the non-admitted, so that's a sort of 0.2 standard deviations relative to around 0.17. So not massive, but there is a difference there. Next slide, please. But then we can actually decompose that and ask, okay, well, how much of that ethnicity gap in each of those subsamples is due to clinical or case mix or explained factors? So our age, acuities, our frailty, our arrival hours, all the things which are decided before someone arrives at ED. And what we see is that by some amount in the admitted population, a bigger degree, to a larger extent, the gap is explained by those case mix, those things that are decided beforehand in the community, if you like, than in the non-admitted population. So there is more, and what we can do from this is infer that there's probably, in the admitted population, there is less that we can do to operationally in terms of tweaking operational flows and things like that are actually going to impact the ethnicity gap here. Okay, next slide, please. So then we're going to flip to deprivation, and these results aren't so large. What we're seeing is, well, the unadjusted results are quite large and quite surprising, but then when we add in age once again, we see those signs actually flip. So there's a slight deprivation gap emerging between. So our reference group here is the least deprived, and we're showing the first quintiles, the second quintiles, and fourth. And what we're seeing is that until we add in arrival hour, for the most part, we're seeing some sort of deprivation gap between our most deprived and our least deprived. Once we add an arrival hour, it's really interesting. Most of those relationships fade to insignificance. So again, what we're seeing here is a big role for case mix and things which are decided before anyone's even set foot in the ED. Sorry, next slide, please. But actually, once again, when we split that sample, split our patients between admitted and non-admitted patients, actually what we're seeing is that the differences is we're seeing in the admitted, this is the admitted population, we're seeing that there are meaningful differences. And we're seeing that once we add in age, we get a big change, but as has been the case all the way through, but actually very little purchase from adding frailty, acuity, and arrival hour. So there is a big difference in the admitted population, but not so much in the non-admitted. Next slide, please. And then to do the similar exercise to before that we did with ethnicity, by a much smaller magnitude here, we're seeing that gap in the admitted population is slightly larger than the non-admitted population, that deprivation gap. Next slide, please, Ru. But interestingly, what we're seeing here is that the admitted that this gap is quite modest, as we know, and we're seeing a similar trend again. In the admitted population, we've got a group, we can explain much of these deprivation gaps through case mix, or things which are decided before people reach the ED. And and there's very little scope for changing ED operational behaviours, which will then influence deprivation gaps. In the non-admitted population, we have a bigger percentage of things which are unexplained by these case mix or upstream differences, and so there's a bigger role for ED operational behaviour to change these deprivation gaps. Okay, next slide. Okay, I'll see if I've got time for this. Actually, I'm not going to include this. I'm going to skip past this. This is a little bit of a thought experiment. Is this just about admission? But I think it's more important that we get on to so Ru can talk a little bit about how this is impacting our work. So again, this is just from an action. So the takeaway from all of this work from us, from doing these decomposition exercises, is that from an action-oriented point of view, therefore, admitted pathways, even though they offer the space where the gaps are greatest between ethnicities and deprivation, they actually, from a secondary care perspective, offer the lowest potential to change these gaps. So if we want to change things for admitted patients, we have to go out into the community, which Ru is now going to talk a bit.
Thank you, George. We got there in the end. So just in terms of summarising and leaving time for questions, I'm really keen that we have some time for questions. I'm going to draw your attention to the bottom of the screen. So a huge amount of the conversation at the moment, if I think about this from a secondary care perspective, from an inequalities perspective, from a broader NHS perspective, is where do we need to focus the very limited resource we have to have the most impact for patients? UECs are under huge amounts of pressure at the moment. And actually what this piece of work has helpfully helped us to disaggregate, delineate and understand is that the work we need to do is to focus upstream of the presentation. There's always work to do in our EDs and in our UEC pathways around productivity and efficiency. But if we're talking about intervening in the patient process and the patient pathway, we need to take our interventions upstream, outside of the ED, before people present to us. And so if that tells me that in terms of how we inform our integrated neighbourhood approaches, the data underpinning demand is so very important. So we went into this work with some preconceptions, with some expectations, and we've been challenged by those. But it's also really helped us to have conversations with partners, with system colleagues, and to start thinking differently about how we manage the demand challenge within our UEC pathway. We know we've got an admitted pathway with a huge amount of demand in it, and there's something about how we recognise the difference in that demand as being medically driven, perhaps more so than the non-admitted pathway. It sounds obvious when you say it, but actually helping us to then determine how you build an integrated neighbourhood offer around health for patients who need to come into the hospital is different for patients than for patients who don't end up needing to come into the hospital. So thinking about how we use our medical model of care and our social models of care and how we deploy those in different ways for different populations. I'm going to stop now because I'd really like to be able to take some questions and have a conversation. And I'm also really happy to share, given the tech problems we had, anything that people are interested in as well.
Thank you, Ru and George, and that was a fascinating presentation, and thank you for coping so well with the tech problems, and apologies for that. We're probably not going to have time for all of the questions, but actually I'm going to, the one that I'm going to pick on is just, hopefully George will give you a bit of an opportunity to talk about the bit that you skipped over, because there's a question from Nora about really interesting the explained and unexplained case mix components in the inequalities group, and just asking if you can expand on that, there's sort of particularly the analytical aspect of that.
Yeah, of course. So yeah, happy to chat about this via email or afterwards, but this is what we call So this is what we call a HACA blinder regression or decomposition. And what we're essentially doing is we're taking the coefficients that we saw in that initial regression exercise and asking how much it is explained by our data mix. So our acuity, I saw another question in the chat about that. We're measuring that both. We tried with EWS, so high EWS, but also with dynamic priority scoring. The results were robust to that. And then frailty scores, so whether we're above the 5 or 7, and then arrival hours. So that's how we're characterizing our explained component of this. It's probably incomplete. There's probably more we could add to it. And then unexplained is just everything that we can't necessarily, that isn't dealt with before someone reaches the front door or isn't. The methodology is pretty involved. Probably don't have time to touch on that in 3 minutes. I know that's a weak excuse. But yeah, really happy to chat about it. It has its sort of grounding in in labour economics and different sources of inequality there, so that's where it comes from. But yeah, happy to talk more about that.
Brilliant. It's obviously generated a lot of interest. There's lots of questions about whether the source code is shareable and also whether there's a report. And if who wants to respond to that?
No report just yet, but really hoping to get it.
Brilliant, thank you. There's also a question about how well the ethnicity data was populated. I know that's can be a bit of a challenge, so I don't know if you can comment on that.
I'll let George answer in terms of this project, and then I can answer on behalf of the trust more broadly.
Yeah. I think you can probably answer better for us.
Okay. Given also that there's been some NHS England kind of mandate and guidance around ethnicity coding, we've reviewed our ethnicity coding, and from what we can see, it's well captured, so it's well documented. But I think we recognise that. So what George described as the ONS ethnicity coding, our EPR doesn't necessarily code by the ONS categories only. And so there is work for us to do around matching up what we have on our internal system with what we are reporting, whether it's here or in another forum. And we also know that it really varies from community group to community group, from patient to patient, day to day. You can ask people on one day, they'll report one ethnicity coding depending on what's in front of them, and then you ask another day and it changes. So there's always a degree of variability with ethnicity coding. All I can really say, and George, feel free to disagree, is that the data that we have felt like it was reasonably complete, but we recognise that there is potential in there for subjectivity as well.
Yeah, I've just seen the question in the chat about frailty. That's our big issue, really. I think we're fairly confident across the board from some of the missing data quality checks I did going into it that was quite high, but I definitely felt like frailty was something we're missing, and I know as a trust we're kind of looking to improve that.
Brilliant, and thank you.
Maybe in general, so the coding element of this piece of work is a recognised caveat to some of the work, but in pursuit of perfection, not doing the work felt like the wrong thing to do. So I think we've gone with what we've got, and I think the areas are for improvement rather than not doing it in the first place.
And I'm going to use Chair's prerogative and just take the last question that's appeared in the chat about what your next steps for this piece of work, because it's a really interesting piece of work, but clearly got lots of potential. So just perhaps where do you go next with it?
So from a kind of trust perspective, what we're trying to do is overlay this piece of work with the integrated neighbourhood team working. So how does this work inform how we develop particularly our city integrated neighbourhood teams? But also, there's George has been doing some other work around kind of demand and on the day, but how does that fit into in day-to-day operational management of patient flows? I think the point, the real take-home point for me around this is the population health aspect of how we predict and manage our demand and respond to our demand. So maybe in 12 months' time, we can come back and share an update on where we've got to. But it does feel like we're at a bit of a juncture of this could go in multiple directions. There's only one of George and one of me, so we have to pick and choose based on patient need, really, and where we need to have most impact.
Brilliant. I'm sure there'll be interest in you coming back in 12 months to update and